come in. I'm really, really excited to talk about ECGs. It's going to be a kind of a whistle-stop tour on ECGs because there's so much you can talk about ECGs. I could talk all day about ECGs, but I'm not going to. You'll be glad to know. Okay, so as nurses, we are expected to monitor anaesthesia, put on your telemetry, put on your multiparameter, and then you're meant to look at this ECG and know, oh yes, what's going on. So lots of nurses always come and say, I can see that it's normal, which is great, or I can see that it's abnormal, but I don't know what's going on. So what do I do? So the point of the talk, hopefully today, is to say, this is okay, this is abnormal, but it's okay, don't panic, or this is really, really scary, and you need to go and get help. So that's kind of the point of the talk today, okay? And I really don't mind if you want to put your hands up and make it interactive or ask questions at the end, and I'm here all day, so come and chat to me. Okay, so obtaining a diagnostic ECG. In practice, do any of you have a machine that can actually print out ECGs, like on paper? Great. And how many times do you use it? No. Are you all happy to get an ECG? Kind of what electrodes and where they go and all that kind of stuff. Yeah. So as nurses, paper ECGs are great, more for the cardiologists, and we have one sitting right here, right in the front, watching me. Paper ECG is amazing. It's really good, but it's more important for the cardiologists because they like to measure, they like to do all the funky stuff that they do with ECGs. So it's really important as nurses that we can obtain a really good trace. But I think the most important thing that you get out of this talk is identifying on multiparameter what an ECG looks like. So hopefully that's going to happen today. But let's go, let's try and get a good diagnostic ECG on paper. So we always ask in cardiology that when you send us an ECG on paper, we get lots of ECGs sent to us to have a look, that the patient is in right lateral. Why? Why do we ask? And that's because all the normal values that we measure ECGs on are done when a patient is in right lateral. You can do ECGs in sternal, standing, obviously it's however the patient allows, but if you want to get good measurements and for us to be able to diagnose, we need the patient in right lateral. We obviously want them relaxed and as calm as possible, which is a bit hard for these patients. They're asking to sort of be laid in right lateral, have these electrodes attached to them, then they have to lie really still. So it's really quite hard, but as much, you can feed them throughout the ECG, give them lots of comfort, lots of kisses, just to keep them nice and relaxed and as calm as possible. You probably all know having the leads shouldn't be over the body because of movement artifact, respiratory artifact, and trembling can cause artifacts. If you've got phones in your pockets, that can cause artifacts, electrical artifacts from tables being turned on, all of that should be turned off. Now, the fun stuff. I was going to go through the conduction system with everyone, if that's okay. You probably all know it, but I think it's a really good kind of baseline to have, the conduction system, so that you can kind of understand what's going on, and it's a really nice moving picture. I think it's quite funky to put in there. So, everyone happy with the conduction system? So I'll quickly go through it. You can see at the top, I want to play that again actually. So the SA node, that's the main pacemaker of the heart. That sits in the roof of the right atrium. That's where it all starts. And if your heart is nice and healthy, that's what's going to determine your heart rate. So if you've got a heart rate of 80, it's your SA node, it's your pacemaker that determines your heart rate. That sends a beautiful signal across the atrius. So your atrius contract. So that's beautiful. You can see the yellow blob going across. Then it goes down to the AV node. Now, this is how my brain works. The AV node to me is like a bouncer on a club. Like you're out clubbing. I don't club anymore, obviously I'm too old. But when you go to a real quite funky pub and you've got a doorman that doesn't let you in, there's too many people in the club, that's what the AV node does, okay? It's there, it's the doorman, it's the bouncer, okay? And it stops that signal coming down straight to the ventricles. It just keeps it there for a little bit, checks the ventricles, yeah, that's good, away you go. And then the signal goes all the way down, the bundle of hairs, the Purkinje fibres, and then it contracts all of that ventricle. So it's a really good, important job, the AV node. Think of it as the bouncer, the doorman on a club. That's how I kind of think of it, the AV node. And as you can see, AV node, bundle of hairs, right and left bundle branches, and the Purkinje fibres. That is the fastest pathway of the heart. So if your heart's working properly, you get a beautiful PQRS ST. Then it could go wrong. So, what are these little waves on the piece of paper that they give you? Your P wave is your atria. It's your basically your atrial depolarization. So that's what happens. If you see a P wave, that means you've got atrial depolarization. So that's quite nice. And because the atrias aren't as big as the ventricles, it just gives you a little blip on the page. Okay? Okay. So then we get the P to R interval. Okay? That's your AV nodal delay. So that's where that Dorman, that bouncer on the club, is just keeping that signal there for a little bit, just to make sure the ventricles are ready to receive. Because if the signal goes down too quickly, it's going to make those ventricles contract on empty. So we want to make sure the AV node is doing a great job. It's making sure the ventricles are ready for that signal. Okay? And then your QRS complex is the massive depolarization of your ventricles. And the reason why you get such a huge deflection is because the ventricles are pure muscle. So that's why you get a massive big deflection. Okay, so then you get your ST, coming towards the end, and that's your ventricles contracting and emptying. And then your T wave is where the ventricles are getting ready to repolarize. So they're repolarizing, getting ready to start the cycle all again. So that's a beautiful sinus. And it's sinus because you've got a P wave, so we know it's coming from the sinus node. So it's P, QRS, ST. That's beautiful. If you see that, yeah, you're all good. So, what are the questions that we ask if we see an arrhythmia? So what is the rate? Really, really important. Is it brady or tachy? Because that's quite important. What is the rhythm? So a nice regular rhythm. You can have any regular, irregular rhythm, and then you can have an irregular rhythm. So there's quite a mouthful there, and you'll see some of these examples. Also, when you look, is there a P for every QRS? So every time you see a QRS, is there a P before it? Are they talking to each other? So are they close together? Are they talking? Is there a QRS for every P? As I said, are they talking to each other? Are they reasonably related? Or are they really far apart? Are they not talking at all? And what I, as a nurse, always keep in my head, is the R wave, the QRS complex, tall and narrow, or is it wide and bizarre? And you'll understand that in a minute. Keep that in your head. Tall and narrow, or wide and bizarre? So, supraventricular rhythms. How do I know that this is a supraventricular rhythm? Remember the AV node, that bouncer, that doorman at the pub, at the club? The AV node sits about here. So anything above the AV node is going to be following the normal conduction pathway. So we know that it's hit the AV node, and then it's going to follow the right and bundle branch, Purkinje fibres, and depolarise that ventricle. So it's following the normal, fastest pathway. Don't know what's happening up here, where it's coming from up here, but it's hitting the AV node, so it's fast. It's coming through the normal conduction pathway, so anything above the AV node is going to be tall and narrow. Okay? So, sinus arrhythmia. I'm going to keep coming over here, sorry, just so you can see. I always look at lead 2, so when you're looking at ECGs on your multi-parameter, try to have it on lead 2 because it looks directly across the heart. It's giving a really nice representation of what's going on in the heart. So you can see P, QRS, ST, P, QRS, ST. So it's a nice sinus rhythm. You've got a little bit of a gap. Sinus arrhythmia, so it's a regular rhythm, but it's a sign of a good, healthy heart. Can everyone appreciate that that's a sinus rhythm? Yeah, happy with that? Cool. So we're really happy in cardio when we see that. Atrial premature complexes. So, these abnormal, tall and narrow or wide and bizarre? Tall and narrow, yeah. So they're coming above the AV node. It's a supraventricular rhythm. So let's identify the red arrows. Sinus, P, QRS, T, P, QRS, T. And then you've got something happening that's coming in early. Can't see a P wave, so I'm not sure if it's coming from the sinus, because I can't see a P wave, but it's tall and narrow. So I know it's coming from above the AV node. It's following that normal fast conduction pathway. So they're called, so what this could be, sometimes we see this in cardiac patients where their atrias are just slightly stretched. So the atria is a little bit excited and it's firing off when it shouldn't be. So we don't get that excited about APCs, do we? It's not something that we get excited about, but we'll watch it. And so this could be that there could be a mild underlying heart condition going on here. We'll watch it, and this could develop into atrial fibrillation. We wouldn't medicate for this, We don't know it's not coming from the sinus because we can't see a P wave, but we know it's supraventricular, so it's coming from the atrias because it's tall and narrow. Okay, make sense? And this is this on telemetry. I thought it'd be quite nice to put in some telemetry pictures because it always looks different on telemetry. It looks lovely on paper, and then you look on telemetry and you think, oh my God, what's going on? So you can see, I can't really reach, but at the top, you've got PQRS, and then you've got some early beats. But they are tall and narrow, so they look like the sinus QRS. So they're supraventricular, okay? And it's not that fast. It's quite a nice heart rate there. Okay. Atrial fibrillation. So, tall and narrow or wide and bizarre? Tall and narrow. So we know it's supraventricular, okay? So this is coming from above that bouncer, that dormant, so it's coming above the AV node, but it's really, really irregular. Has anyone heard atrial fibrillation? Yeah, once you hear it, it's like chaotic rhythm, and it's known as a chaotic rhythm. If you've ever had to wash your trainers in a tumble dryer, and it goes bum, 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 bum. That's what this sounds like. So if you ever hear this, you'll know it's atrial fibrillation. It's a really cool rhythm to listen to, actually. And actually, the animals are okay. We have lots of animals walking around, even people walking around with atrial fibrillation, and they can live quite happily with it. We just have to slow down the rate. So we know that it's a supraventricular rhythm because it's tall and narrow. I can't see any P waves, so I don't think it's coming from the sinus node, but I know it's coming from above the AV node, and it's really irregular. You can see that the R waves, they're not regular. It's very, very irregular. So what this is happening is the atria is probably really stretched due to an underlying cardiac condition, and the atria is just fibrillating. And it's firing, it's literally firing loads of signals down to that AV node, that bouncer, the doorman at the club, firing down this signal at like 400 beats per minute, even faster, ridiculous amounts, firing it down, and that bouncer, that doorman, is like blocking it as much as he can, which is doing a great job. And then he's letting these signals down. It's being bombarded, it's letting these signals down at such an irregular rate, and this is why the ventricles, the R wave, is contracting at different rates. Does that make sense? So you see no P waves, irregular R to R, sounds chaotic, like you've chucked your trainers in the tumble dryer, it's probably going to be atrial fibrillation. And the key to this, so the patient may feel a little bit not great, pressures might not be amazing, probably still walking around quite happy, living life, probably has an underlying heart condition, but what we would do in cardio, we would control this rate. So you can try and convert by doing a cardio version where you shock them under anaesthetics, but with this we would just give them medications to slow down the rate. Okay. But if you ever hear, if you ever have a patient that's got atrial fibrillation, please go and listen to it. It's a real classic rhythm. So this is, I didn't get a moving picture, but this is atrial fibrillation. And look, it's 230. But the atrias are probably contracting at about 400 beats per minute. So we have to control this rate. This is not great for these patients to be, beaten at 230. So, tall and narrow, wide and bizarre. Tall and narrow? I've lost you all now. It's tall and narrow, okay? Can't do any P waves, but it's very regular. So in my head, I'd look at this and think, this is a supraventricular, but I don't know whether it's sinus, I don't know what's going on. And we get lots of patients like this, and it's quite regular. We have quite a lot of patients like this that come, and actually they don't have an underlying cardiac disease, but they are in pain. So this is patients that could be in shock, they could be painful. So what we would do with these patients, obviously this is a really fast rhythm, this could be like 300 beats per minute, so we can't let this continue. So we would do a vagal manoeuvre and see if we could slow this rhythm down to see if we can identify, is this a normal sinus rhythm underneath, or actually is this a true abnormal rhythm? And there we go. So you've got an SVT there, supraventricular tachycardia, 174. This patient's not going to be feeling great with a heart rate that fast. So we need to do something about it. But do we treat it as an arrhythmia, or do we try and slow it down to see, actually, is there an underlying reason for this fast heart rate? Ta-da! We did a vagal manoeuvre. So you can see your SVT at the beginning. We did a vagal manoeuvre, and in dogs we do a carotid massage. You can also apply pressure to eyeballs. Not ideal. Or in cats you can press on their nose. just a sort of a hard press on their nose, do a vagal manoeuvre. But in dogs, we do a carotid massage. There is a precordial thump that you can do, but I wouldn't recommend that. And then we broke it. We went into sinus rhythm. So that's great. So we know that this hopefully is not a cardiac condition. We can identify we've got a beautiful sinus. Everyone happy that we can see sinus at the end? And this could just be pain related or anemia. There's loads of different things that can happen here. So it's quite a nice thing that we managed to capture. Now the real interesting stuff. So anything that happens below the AV node is ventricular. So it hasn't come from the H's, it hasn't passed the AV node, it's starting in the ventricles. So this is where it gets, I say it gets really juicy, and I don't mean that in a bad way, because obviously we always make sure our patients are okay, but it gets really quite interesting now. So, okay, VPCs. Can everyone identify what's abnormal on the ECG trace there? So you can see sinus. I come across. You can see sinus, and then this is tall and narrow or wide and bizarre? Wide and bizarre, yeah. So there you go, there's a VPC. We'd look at that and there's some VPCs, that's quite nice, but one thing we do look at is we look and see whether the VPCs all look the same. Now I know in the different leads they look different, but if you look at lead 2, so the second, that one there, yeah. Thank you. You can see that all the VPCs, the wide and bizarre, look the same. So that's okay. So that basically means that the ventricle is firing off, it's unhappy for whatever reason, but it's firing off from one part of the ventricle. So just one little bit of that ventricle could be unhappy. Now that could be pain related. It doesn't mean it's going to be a cardiac reason. We would probably monitor this because there's quite a few actually. So we get patients that are having echoes, they're a little bit worried and they may chuck a VPC. Okay, that's not too bad. With this, there's quite a lot in this short space of time, so we maybe put a halter on and see how many VPCs in 24 hours. So this is a wait and watch kind of thing. But I'm not too concerned because the VPCs all look the same. So to me, that means there's just one part of the ventricle that's happy. I'm unhappy, not happy, unhappy. So there we go. So this is a nice telemetry picture. You can identify PQRS, and then you have these wide and bizarre complexes. So that's your VPCs. So this is a wait and watch. We'll have a look and see what's going on. Okay, now we get a little bit more interesting. So we have VPCs, so the red arrow and the blue arrow. You can appreciate that they're wide and bizarre, and in between you've got your lovely sinus. Now the reason why it would be a little bit like, oh, this is quite interesting, is because they look different. So the two VPCs, they just look different. So we call them polymorphic. They just look different. So that means that there's two parts of the ventricle that is slightly unhappy. So you kind of start to think, oh, this isn't great. So we would be a little bit more keen to investigate this and see how often this is happening, how fast they are, and do we need to treat? Yeah, everyone happy with that? Okay, so this is telemetry. It's not moving. I'm sorry, there's a kind of a big light bit there, but I can't do anything about that. Sorry. So this is kind of, there's quite a few VPCs here, and they're looking different from each other. So we would definitely want to have a look at this patient, maybe scan, maybe do some bloods, and see if there's anything that we need to intervene with. Still not fast though. We're okay. Whoa, now this is getting juicy now. Look at this. So we have a sinus, which is the blue. Then we have red, which is a couplet, so two VPCs. And then we have non-sustained VTAC. So we kind of like to use these big words. It makes us look clever, but it's not really. So 2 couplets, 3 triplets, 4 salvos, non-sustained VTAC. And that's, you've got the whole shebang there, which is really, really quite cool. We would be very concerned about this. we would definitely do something about this. We'd be very, very interested, but of course we'd make sure the patient was safe first. And you can see the green, they're happening really fast. They're coming very close together. So this is a ventricle contracting on empty. This is not good. This patient would be feeling quite poorly. You've got kind of like, when they run really fast like that together, like the green bit, it means your ventricle is just contracting. So it's not having any time to fill. So literally very limited cardiac output at these periods. Okay. Now. Okay, yep, so there we go, we've got some telemetry. 224, they're coming quite fast. You can see, so they look slightly different, but this is because they're coming from different parts of the ventricle. You can see in between, they're competing with the sinus. You can see the PQRS, but the ventricles, the wide and basal complexes are also coming in. So you've kind of got your sinus node competing with what's happening in the ventricles. They're competing with each other. That's why you get sinus and you get the ventricular rhythm, okay? Oh, look at this. Right, ventricular tachycardia. Woo! This, I mean, sometimes when I see this, I think my heart does the same. Because I'm like, oh my God. So this is, you know, this is fun stuff. So this is, if you see this, don't film it, don't watch it, do something about it, okay? We get very, we get very excited about stuff like this. Making sure the patient's okay, I have to keep reiterating that. Because we can. This is what we do in cardio, we make sure they're okay. This is a very, very naughty rhythm. Yeah, this is scary stuff. This stuff, lidocaine. We'd make sure we got an IV in, this is lidocaine. We tend to do 3 boluses over a 2-minute period. You have to be really careful with lidocaine because it can cause neurological symptoms. And I have done that, but I first started out in cardio. We had this rhythm and I squashed in the lidocaine because I was so scared. The patient had some neurological symptoms and it was fine, thankfully. So I've learnt. So you have to give lidocaine slowly over 2 minutes. We tend to give 3 boluses. We'll also give an antiarrhythmic, something like Sotalol as well, but that takes a while to take effect. Very close monitoring of this patient. And even a COI of lidocaine. And then obviously we would have a look and see underlying cardiac disease. But this is naughty. And there we go. This is on telemetry. Of course, whenever someone's filming, there's always somebody dealing with the patient. But it's just nice to have it on there on telemetry to see it. So that's VTAC, that's sustained VTAC. So that's not nice. The next picture I've got, I believe, I just wanted to show you, but I'm going to just say something before I show it to you. I believe it's the cardiac patient that we had during the cardiac intervention. And it just shows that how things can suddenly change. The patient was absolutely fine. You'll see some anaesthesia heads jump up when it gets a bit juicy. This is a cardiac intervention. We're tickling the heart, and hearts don't like to be tickled, which is fair enough. So I was filming this, I think my heart, and then it gets really quite interesting. It kind of changes morphology, and then there we go. And it takes a while for the telemetry to pick up. Yeah, there we go. And then anaesthesia kind of jump up, we need to do something. But isn't that amazing? Isn't that? And the dog, absolutely fine. It just didn't want its heart to be tickled. So, it's cool. And I think we had to turn the sound off because there were some few words that we... but yeah, amazing. Really cool. Yeah. Oh, that's very exciting. But obviously during interventions we have anaesthesia there, we have pacing pads on, we can intervene. This dog is absolutely fine. So, and yes, and woke up and didn't know all the excitement that it caused during anaesthesia, which is good. Okay, fibrillation. Has anyone seen this with crashes and stuff? Yeah, there's not much really to say about this. This is end stage. We would, the only kind of thing to do here is use a defibrillator. There's not, I don't think there's any medications. Last resort, you can give amiodarone, but this is a defib situation. You would start chest compressions for 2 minutes just to get the blood moving around, and then you would defib. And I'm not showing pictures of fibrillation because that's not right. So, but yeah, this is the worst rhythm that you can have, basically, in a crash situation. So, and it's the ventricles fibrillating. It's just not any organised rhythm at all. It's just fibrillating. So, yeah, not nice to see. So, this is a real mouthful. Accelerated idioventricular rhythm. Okay, so any of you that work in emergency places, or any patients that have got something going on systemic. If you've got a gastric torsion, I'm sure many of you have done that. Anything, like a splenectomy, and you put your patient on telemetry, it's quite often you will get a ventricular rhythm, because this is ventricular, it's wide and bizarre, absolutely. But you can see at the beginning, you've got some sinus, which is great, and then you can see there's a ventricular, but it's not that fast. It's okay, it's ventricular, but this is due to something systemic going on. It can cause a ventricular rhythm. So there's a bit of telemetry. It's not that fast. It's 123. Yes, it's ventricular, but we don't worry about this. It's because if you treat the underlying condition, whatever going on systemically, then you will treat the rhythm. Okay, so we see this an awful lot in ICU. It wouldn't be wrong to do lidocaine, but it probably won't work. So it's a complete rhythm that you see, and you would think, oh, it's ventricular. Absolutely right, but it's not a scary rhythm. The difference between AIVR and VTAC is anything up to about 150, 160. Patient looks good, blood pressures are okay. It's generally AIVR, and there's something systemic going on. 160, 170 is a grey area. You want to check your patient, check your pressures, look at them clinically, do obviously all your checks, because it's kind of a grey area. But anything over 170 is VTAC, and that's when you start to get your pressures dropping, your patient's really unwell. So, so I just wanted to point that out. It is a ventricular rhythm, but it's not something that you would generally treat because there's something underlying going on. So I'm coming to the end, but I just wanted to put on there, it's like a whistle-stop tour of ECGs, but there's loads of different rhythms. There's, all your blocks, your first, your second, your third degree AV blocks. During anaesthesia, you've probably noticed them, like you get quite often with certain anaesthetic drugs, you get first degree AV block. You get some really cool third degree AV blocks where we go in and do pacemakers. You get ventricular escape, sick sinus, so there's so many different patterns on an ECG, and I could talk all day, but I haven't given me all day to talk. So, ECG tips. Just the last thing I wanted to say. Remember that doorman, that bouncer on a nightclub. Anything above the AV node. There's always an exception to the rule, so don't hold me to it. But generally, anything above the AV node, tall and narrow, supraventricular. Anything below the AV node, that doorman, wide and bizarre, is going to be ventricular. I would always recommend, if you can, with ECGs, because nurses always, we are expected to check these rhythms, and it's really hard when you're not doing it every day. And you can see my phone. I'm a nerd. I video all the ECG tracings. So if you're doing a anaesthetic and it looks normal, film it. The patient's stable, obviously. And if you can get into the practice of just recording or getting all your colleagues to record ECG traces, because you may pick up a first degree AV block and not even realise it. And then if there's an abnormality on the ECG during anaesthesia, do an ECG when the patient's awake. And has it changed? Was it drug induced? So that's what I do. That's how I kind of try and learn and keep on learning ECGs. I video all the ECG traces and just practice. Yeah, that's it for me, I think. Yeah, thank you for listening.